The next hour, we're going to go into the world of neurosarcoidosis with Dr. Tarunya Arun and Dr. Claire Rice. Tarunya is, I can't even speak this morning. Tarunya is a consultant neurologist at University Hospitals Coventry and Warwickshire, and Claire is a consultant neurologist and associate professor in neuroinflammation at the University of Bristol and North Bristol NHS Trust. After their presentation, we'll take a short break and we'll return for questions after that break, though. So let me hand over to Claire and Tarunya.
So, Graham, thank you. Thank you so much. Thank you to SarcoidosisUK, and thank you to you all who kind of joined this morning for this patient day. This patient day has obviously been happening for the last several years, actually, and SarcoidosisUK have obviously kept that up, sort of trying to update people on sort of, new happenings, and then obviously inviting us all. We're really privileged to be here, so thank you so much. So I'm, as Graham just introduced, I'm a consultant neurologist. I specialize in neuroinflammation, so all things which involve inflammation of the brain and spinal cord, and also the peripheral nerves. And what we're going to do today is Claire Rice, who my colleague, who you'll hear from in a little while, and myself, we are going to just split the hour to discuss and then bring you up to date with a number of different things. So my role this morning in the sort of half an hour or so is to talk to you about the pathophysiology of sarcoidosis, and then what sort of underpins some of the later sort of discussions which will come around treatment, for example, and then what sort of differences exist amongst us, why some people have some forms of disease, whereas some others have got different other presentations, and what would be the core clinical features which actually many people notice as being the key features of sarcoidosis, and some of those hidden sort of symptoms as well. And in the second half, I'll pass on to Claire Rice, who then will discuss treatments associated with sarcoidosis. And then we'll obviously join up to answer some of your questions via the Q&A session. So again, from my previous talks and also obviously from your own sort of readings about sarcoidosis, you might be aware that it is an inflammatory condition. So it causes inflammation. And really, there isn't a single organ in the body that is spared from sarcoidosis as such, which makes it a really important condition to work on the basis of a multidisciplinary team, which is what you'd have this morning hearing from a lot of different specialists. So in people from sarcoidosis, the main culprit, as I call it, are these abnormal masses or nodules called granulomas. And these happen in different organs and really sort of underpin what trouble this condition actually causes. These granulomas alter the normal structure, so that could be within the brain, it could be within the lungs, it could be within any organ that you possibly have within the body affected by sarcoidosis. And as a consequence of altering a structure, it can alter obviously the function of that particular organ, whatever that might be. So just dwelling a little bit on this granuloma, which, so that is a brain section of a patient that we looked after, one of the many patients we looked after, looking at the biopsy of the brain tissue itself. So what underpins is obviously your immune system. So sarcoidosis is very much an immune-related condition. And that's not a surprise at all, because many of you might have family members who've got different autoimmune conditions, and very often that forms part of the discussion when you come to sort of obviously see us in our clinics. And really, it is an interaction between the two large kingpins of inflammatory disease or immunity, really, which are the B and the T cells. And the B and T cells then results in a cascade of processes, which then ultimately culminates in the formation of this granuloma, which we just talked about. And why why this becomes important for us to kind of understand why these cells and how the cells interact and why they interact in the way they do is that some of the treatments which we have for sarcoidosis presently and some of the experimental treatments which are currently being looked at for sarcoidosis are all dependent on these various interactions. Some treatments which already licensed and presently, for example, the TNF-alpha treatment, which is obviously an interaction between the macrophages, which produces some of the reactions resulting in a granuloma, which you're aware of. You know, the IL-6, which then, which is another interleukin, which is being targeted by some of the treatments we currently use for sarcoidosis. And luckily, there is more and more research which is sort of discovering a number of different pathways which are involved in the pathophysiology, which means that there is real hope in understanding pathophysiology and thereby influencing treatments for this fairly devastating condition. Now, sarcoid, as you know, is obviously a multi-system condition, out of which really the incidence really varies. So depending on where you look at with the condition, so the highest incidence, we'll come to that in a few slides down, is the highest incidence is among the Northern European population. So worldwide, the incidence is very different. So obviously, the number of people affected by the condition worldwide differs depending on where you are. So the figures within the UK may not be particularly relatable to the figures perhaps within Northern Europe or within the Southern Hemisphere, where the incidence of the condition actually differs. But what we do know is that wherever you live, the African American Black population have roughly about 3 times an age-adjusted incidence when compared to the European Americans. In a study which was done within the UK a number of years ago, sort of found that with the incidence in the UK is about 15 per 100,000 as such. And it does have a consequence, which is why it's important to kind of recognize, treat patients early, and also make sure that they do not have an alternate diagnosis. There's also a higher incidence of autoimmune conditions for sarcoidosis, particularly hematological and skin cancers, particularly more prominent among patients with sarcoid, which becomes really important because some of these treatments have got different, some of these conditions have got different treatments, and some of them mimic each other, which is why it's really important the diagnosis keeps that in mind without obviously sort of making sort of errors within the pathway of diagnosis, because treatment implications are quite different for those conditions. Neurological involvement in sarcoidosis is a small percentage of the whole sarcoidosis sort of spectrum, but obviously it's a very important one. So up to 10% of patients can have neurological involvement, depending on where you look at. And then most importantly, there is remission only in about 1/3 of patients. Only about 1/3 of patients get back to normalcy completely. And then rest is associated with obviously mortality, but obviously morbidity, which you're all aware of, which can be a significant sort of problem all through someone's life. Now, this is a sort of a map or a color map, essentially showing you about what the differences are in the way we encounter sarcoidosis across the world. From what you can see from that, the lowest incidence, so what this graph really shows is the prevalence and the incidence, so essentially being the number of cases that you have per 100,000 inhabitants in a particular area, and what would essentially be on an annual basis, what would be the number of cases which people actually find within this particular condition, and what would be the total number of cases which one would essentially find of that particular condition at any one point in time, would essentially be demonstrated by those graphs. So what you can see from that particular graph is that the red, which you can see on the top map, is the area where you would essentially at any one point in time on a yearly basis, you would have more than 10 cases which are being diagnosed on an annual basis per 100,000 population. So really the incidence is significantly higher when you look at the Northern European population. So for example, if you look at the Swedish, the Norwegian population and their descendants, people from the Netherlands, for example, would have a high incidence of neurosarcoidosis on sarcoidosis by itself. and then also higher within the Northern American population, and the lowest being within the Eastern Asian countries. Again, that is not somewhat sort of surprising for some of us who look after other autoinflammatory conditions, MS, for example, other inflammatory conditions, neuromyelitis optica, more, for example, primary biliary cirrhosis, and other conditions which not necessarily just affects the neurological system, but across the body, is that this pattern which you see for sarcoidosis with that divide across hemispheres is also very much predominant for those other conditions which we see, which again, as I say, could be very much prevalent within either families or patients who suffer from that condition themselves. So independent of geographical location, people of Black and African American ethnicity have got a higher incidence, so 2 to 10-fold, depending on where you look at. And then very important to sort of know that, again, from the ethnic determinants point of view and also from the health equality point of view, first, sarcoidosis-related symptoms occur within the Black American African population, with obviously with an earlier incidence. So it's not unusual for children to be diagnosed with sarcoidosis, for example, within those groups. And then obviously we do look after patients from just not sort of the Black African American ethnicity, but also the Nordic population who have been diagnosed with sarcoidosis sometime in their primary school years. So that's really is not unusual. And then the diagnostic biopsy, so showing that someone's got sarcoidosis, is somewhat 10 years earlier. So very often biopsies, either from the lung, we had recently sort of seen people in clinic who've essentially had skin biopsies suspecting eczema in a child which is responsive to treatment, who was subsequently diagnosed with sarcoidosis. And then they also tend to have a higher granuloma density. So granulomas which underpin that organ disruption, which you see within sarcoidosis, is also about 2-fold higher within those populations. And more specifically, they required sarcoid-specific treatments. So as you'll hear in the talk, which is later on, sarcoidosis treatments essentially are varied. Some of them are sarcoid-specific treatments, and some of the wider treatments which we use, because not all patients require sarcoidosis-specific treatments, but we see that people with certain ethnic determinants have more severe disease, so the higher incidence of using those treatments. Again, poorer prognosis. So for example, irrespective of what you use with treatments, we also see that there is a higher incidence of using, say, second and third line treatments within patients, particularly people who've got a longer duration of having had the condition. In respect of both disease severity and also mortality and morbidity, the prognosis tends to be much poorer within those populations. And obviously, higher incidence of hospital admissions. So again, if you see a hospitalized populations, a lot of those populations belong to this particular ethnic minority determinants. Now, the age, obviously, this is an evolving scene. So there's a lot more epidemiological work, which is basically work looking at the ages, the gender distribution, the geographical and also the racial distribution of sarcoidosis, much more within the last 10 years than there has ever been. More work, which is sort of obviously growing. So what you can see from that particular graph is obviously there is a peak age incidence between the ages of 20 and 50 years of age. That's not to say that we don't diagnose patients, as I said, who are much younger, and also people who are much older. So we do have patients being diagnosed in their 70s, and that not very uncommonly. So the peak incidence in males is usually between 30 to 50. So this is essentially sort of underpinning the differences between genders. So males usually tend to be a little bit younger when people are diagnosed, and then the peak incidence for females is a little bit older at 50 to 60 years of age. There are also some studies which have shown a bimodal distribution, which means to say that obviously there can be 2 different peaks of ages when people most commonly have the condition being diagnosed. Now, I think this is somewhat really important. So to recognize that there is differences. And why is it important for us to know that there is a difference in age and then gender or sex, and also the racial sort of predominance of the condition, is because the organs which are affected are somewhat different. So this is not to say that people do not have organ involvement in that particular sort of group at all of a particular type, but really, you would be having that much more frequently. For example, you do have an incidence. For example, if you look at populations, very much sort of the Asian populations or populations in the Far East populations, that tend to have a higher incidence of, say, extrathoracic lymph node involvement, for example, abdominal lymph nodes or lymph nodes within the neck are perhaps much more common. And we notice that when we have to diagnose people with biopsies, there's also eye involvement, much more common within the Japanese population, and again, skin involvement. So you do find fairly a very sort of significant skin involvement basically seen within not only the Eastern population, but also within the Black population. And obviously the ethnic populations of the sort of the Black and the white populations tend to have more incidence of neurological involvement, whereas you don't often see that very commonly within Asian populations of people coming from the Far East. Now, again, depending on whether people are male or female, there's a slight difference. For example, males tend to have a higher incidence of cardiac involvement. So very important to look for evidence of cardiac disease within people who present within our clinics, whatever specialist clinics, whether it's neurological, respiratory, skin or eye clinics as such. And there's a higher incidence, obviously, of females having skin and eye involvement. And then if you look at the age differences, within sort of reason, obviously, the higher the age, people tend to have CNS involvement. It tends to become much commoner, whereas the classic Lofgren syndrome, which is obviously the fever, the parotid gland, and the lymphadenopathy, which people actually develop, tends to very often a young patient having that particular spectrum of symptoms or signs which actually come within that particular group. This is something which is, I think, really important to kind of recognize and think about, is obviously the genetics within sarcoidosis. I know Dr. Braithwaite just touched upon, obviously, the genetics and the importance of this. This, again, is very much sort of something which is a growing pot of information. So we're knowing more and more about what involves the genetics within sarcoidosis. And what you can see on that particular graph is obviously the number of different chromosomes and what genes are affected. So the ones on the red, so on this particular slide, the letters on the red, or the gene or the genes which you can see, which have been marked on the with the red sort of ink, are the ones where in more than one study this has been implicated within the sarcoidosis as being important within sarcoidosis, and the blue where there are single studies with growing amounts of information. And really understanding the genotype of sarcoidosis, or understanding what genes might cause sarcoidosis, is really important to also understanding what particular phenotypes or what particular presentations people might have with sarcoidosis. It's not uncommon for you to sort of find people with not only other forms of sarcoidosis, but also slightly different forms of just neurological involvement sarcoidosis, which do not respond to the same treatment. And what might be the answer to all this is understanding the pathophysiology and the genetics of sarcoidosis, so that people can be treated in a very personalized or very individual fashion, rather than the mass treatments as we understand it at the present. Now, this is again something which you might encounter, is very often asked when you come to clinics about family history with sarcoidosis. As I said, autoimmunity is very common, but also the incidence of sarcoid is very common. So the tall bar which you see on the left-hand side of that particular graph is obviously it's what we call identical twins or monozygotic twins. If you have an identical twin with sarcoidosis, you've got an 80 times higher chance of having sarcoid. It also follows for any other sort of twin which you might actually have. And again, siblings having 3 to 5 chance of higher incidence of sarcoidosis, not necessarily sarcoid involving the same organ, sarcoidosis in general. And as you can see, the really tiny bar, which you can see right on the other side of the graph, is a normal population. So there's a real genetic, there's a real family sort of trend to sarcoidosis, so higher incidence within that particular group. Why this becomes important is obviously to think about sarcoidosis diagnosis in people who already have a family history. So having a lower threshold for recognizing that those symptoms which people report, or people, what you might find within the tests which we do, might actually be quite important within that particular group as such. Now, very often, patients I see in my practice, and also people who within sort of other sarcoid clinics, are very often asked what causes sarcoidosis, what is the cause for sarcoidosis as such. Now, there's, as I said, there's a lot of work which is currently undergoing, but I don't think we have really pinned down what might cause it. We do know that it's a mixture, or what we call it's an interplay between environmental factors, so depending on where people might work, where people might live, for example, and what sort of occupations people might have, but equally it also depends on an interplay with genetics and other factors which we've just discussed. So it's basically a composite. There are several intriguing clues. For example, the World Trade Center bombing, sort of first responders had sarcoid-like disease. So one might wonder whether that might be related to some of the environmental sort of factors coming from that particular sort of highly dusty environment in which people were. We also very often see seasonal clustering. So the busiest time within sarcoidosis practice will often be within spring time. Again, slightly dependent on where you live. There's also higher risk within the summer times as well, where people feel that their symptoms are much worse. That's not just associated with sarcoid by itself, but also with other neuroinflammatory conditions. And then within sort of the latter part of the year, this is again not to say that people don't have symptoms. So several of you might have experienced increased symptoms during winter and autumn times, but generally there's a fall of incidence within our practices. Spatial clustering. So for example, we already talked about the north and the south, but there also seems to be higher prevalence, especially within certain regions, perhaps with something to do with environmental and genetic influences, and clustering of populations with a similar genotype, that there might be higher incidence as well. You also see higher incidence of cases within certain miles, so certain parts, even within the UK, have got a higher incidence of sarcoid. So certain clinics might be much busier than some others, purely because of the fact that there is a degree of clustering depending on where people actually live. And again, the clues for all this will hopefully come within the next decade or so, as we're essentially learning more and more about what causes these these influences. Now, I'm just going to move on from what we've just been talking. So what underpins sarcoidosis? Pathophysiology, genetics, environmental influences, to what do people actually experience with sarcoid? So what are those clinical symptoms which people actually see with sarcoidosis? Now, the frequency, so this is a work which we did a few years ago to essentially look at what was the so in people with neurological sarcoidosis, so we looked at about just low 80 patients with biopsy proven sarcoidosis. So these people are patients with biopsy confirmed sarcoidosis within our practice. We found that majority of people, it doesn't come as a surprise, a lot of you who are neurosarcoidosis sufferers might also know that there is a higher incidence of pulmonary sarcoidosis. You would also be under the care of a respiratory consultant. Very often your diagnosis would come from a lung biopsy or from a lymph node biopsy. So lymph nodes, again, very common second site of occurrence. Ocular sarcoid, skin being an important site of diagnosis, joints and bone, for example. So very often in people for an unrelated reason, for example, when we scan spines of people with neurosarcoidosis, very often we see punched out lesions within their bone. People with sarcoidosis often do not complain of bony pain with those, but very often we see them on the scans as what we describe as incidental bystanders, but nevertheless are present. We also see glands. So very often people with sarcoidosis might find that their glands, particularly their salivary glands, might go up and down depending on how they experience other symptoms with sarcoidosis per se. So what we call a sialadenitis, cardiac involvement, again, really important. So there is a higher incidence, obviously, of subclinical cardiac disease. So very often, many of the patients who come to my clinic, many of the patients who come to other clinics would have a PET scan so that we can actually see what else is going on elsewhere within the body. And not to forget all the other areas which can be involved. For example, people involving liver, spleen involvement, kidney involvement. Very often we diagnose kidney sarcoidosis in patients who have been told that they have a completely different kidney condition, and that's something to be borne in mind. Now, this is a summary of the frequent various neurosarcoidosis manifestations. This is also from the same piece of work where we essentially found that the spectrum is really wide. We see pretty much everything in different patients. Not the same patient has all these different symptoms or problems which come, but really important to sort of recognize these limb weakness, people presenting with headaches, sensory disturbance, unsteadiness. And then obviously, as we go sort of, well down that particular graph, you'll also start seeing things like stroke, for example. We do have rare, but sort of one case, perhaps ever so often, once a year, once every couple of years, when people actually present with a stroke with their sarcoidosis. And there are several in the middle, for example, pain and fatigue, not necessarily related to those granulomas eroding organs, but particularly as a consequence of having sarcoid by itself, people suffer from chronic pain and fatigue. And then obviously dizziness and vertigo, which people might sort of recognize, again, not sometimes a direct consequence of having sarcoid-related granulomas, but as a consequence of having had the condition, people essentially have neurological symptoms associated with it. And then, of course, the more serious varieties, for example, having seizures associated with sarcoid, or people having drowsiness and other involvements of what we call the brain parenchyma, or the tissue of the brain itself. Now, what I do is run through some of the slides. So some of you listened to some of my previous sort of talks would perhaps see that some of this is perhaps just reiterating some of the points which I made previously, but really important to sort of recognize cranial neuropathy. So very often people have involvement of their facial nerves, or it's not uncommon, again, for people to have a more severe involvement of their neurosarcoid, come to clinic, and when we actually speak to them, they've had facial nerve involvement a number of years ago. Diagnosed as a virus, diagnosed as something else, but facial nerve involvement is very common. So almost 3/4 of patients having facial nerve. So that can be one side, that can be both sides. It can be mild, they can be lasting symptoms, and that's really kind of quite common. You again just had a fantastic eye talk where there has been a number of things touched upon, but optic neuritis, again, really important to consider this in someone in whom the optic neuritis hasn't really responded to standard treatment. So there are viral causes for optic neuritis. It still remains a very common cause. But again, conditions such as multiple sclerosis cause optic neuritis, but the recovery in cases of sarcoid optic neuritis can be very different, which then leads us to then diagnosing neurosarcoid in patients who then had poor recovery from their optic nerve function. And in about 1/3 of patients, it's sequential. For example, one eye is involved, and then you have the other eye being involved. Sometimes both eyes are involved by the time they reach a neurologist or an ophthalmologist, and that's, again, not uncommon. Then, of course, there's a spectrum. Again, several of you on this particular session and people who suffer from neurosarcoid probably have other involvements of the audiovestibular nerve, which is obviously the nerve controlling the balance and the hearing, is seen. This is very often refractory to treatment, so you might find this occurring in people already on sarcoidosis treatments, and very often is very difficult to treat as such, because balance difficulties in sarcoidosis are extremely difficult to treat. People also have what we call refractory sarcoidosis if treatments obviously if people are no sarcoidosis treatments at all, when they develop those symptoms, they tend to be a bit more difficult to actually end up getting complete resolution of symptoms in. And then, of course, various other symptoms, for example, numbness of the face, or what we call trigeminal nerve involvement, and then involvement of a number of other nerves of the eye, or what we call the extraocular muscles. So, and very often that is somewhat a concerning symptom as far as a neurologist goes, because it very often brings with it a number of other facial nerves which are involved. For example, the facial nerve can be involved with the extraocular muscles, and what we call multiple cranial nerve involvement, which is again not uncommon. Now, meningeal involvement, or involvement of the coverings of the brain. So this is it's of various forms. So this can be in the form of people having headaches, or what we call aseptic meningitis. So aseptic essentially means that there is no infection. So people might go with headaches and neck stiffness, a lumbar puncture is done. You don't often find anything going on within that lumbar puncture, excepting that the cells within the lumbar puncture fluid might be higher. People might sort of have elevated protein, but irrespective of what other tests you do to grow bugs within that, you might not actually grow them. So hence aseptic meningitis. And that can wax and wane. So people can have a number of episodes of aseptic meningitis. Sometimes all the coverings of the brain can be involved, so which is basically called pachymeningitis, or what we call thickenings or thickening of the sort of the surface coverings of the brain. Now, this can be less aggressive or it can be more aggressive. People can have what we describe as cavernous sinus syndrome, so pain behind the eye with involvement of all the nerves, which I just showed you, which causes cranial neuropathy. So having double vision, for example, and excruciating pain can be very difficult to diagnose because that area is not a very easy area to biopsy, very often mistaken for other things such as benign brain tumors or other growths, infections, etc. So that can be very important to sort of diagnose. Leptomeningitis, which is obviously the covering of, which is the closest to the brain, so the surface coverings which are closest to the brain, and obviously as it seems intuitive, that seems to cause the most severe forms of sarcoidosis that can block off. So as you know, that the coverings of the brain essentially also have fluid which sort of circulates within the brain, so the coverings of the brain then having inflammation would also mean that not only all the cranial nerves which are coming out of it is basically affected, but also you can have the sticky sort of coverings of the brain cause the CSF flow or the spinal fluid flow to basically not happen as freely. So people's spinal fluid systems can get clogged up and have conditions called as hydrocephalus. Again, not uncommon for us to see cases of people presenting with hydrocephalus, or what we call fluid accumulation within the brain, as a very severe form of sarcoidosis, very often requiring prolonged periods of time within intensive care units, for example. And it's associated with a poor outcome, so which is why it becomes really important to diagnose this form of sarcoidosis really early and treat. So from personal sort of practice, these are patients who often require a shunt, a brain shunt. They often require other forms of treatment. In addition to that, in order to keep sort of the brain inflammation very much under control. And of course, there can be permanent impairment of cognition. There can be permanent impairment of your pituitary function, and also motor, sensory, and balance disorders, or what we call legacy symptoms from having very severe leptomeningeal involvement. Fortunately, this involvement is quite rare when compared to some of the others I've just showed you on the previous slide, but it is a very important one to sort of recognize and treat. And then we have parenchymal involvement, where there's involvement of the brain tissue itself. So this very often is perhaps the most aggressive form of the disease, very much in the same sort of level as the leptomeningeal involvement, where people actually have involvement of the actual brain tissue. So people presenting with seizures or fits, for example, or motor weakness, for example. And very often diagnosis is either by a specialist radiology review and having biopsy from somewhere else in someone who already has sarcoidosis, a very first time presenting with sarcoid, or sometimes by brain tissue biopsy. So this is a patient of ours on that particular sort of instance, diagnosed with a brain tumor in the first instance. Treatment for the brain tumor was obviously thought to be terminal. Patient was then diagnosed with sarcoidosis because we felt brain biopsy was really important in this particular case. And then patient then diagnosed with sarcoidosis. And I'm very pleased to say that patient's completely recovered, that person leading actually a fruitful life. So really important to sort of recognize those other causes which might mimic it and think about having obviously low threshold for seeking out tissue. Equally, sarcoidosis can be look like other conditions might look like sarcoidosis. So very often sarcoid-related treatments do not work, which is why it becomes important not to diagnose the condition lightly and then look to seeking tissue biopsy where possible for that particular condition. Then you have hypothalamic and pituitary involvement. So this is, again, involvement of the pituitary gland. So people having a number of consequences, for example, involvement of the downstream effects, such as thyroid involvement of their sort of gonadotropins, so fertility issues, for example, or diabetes insipidus, where people might actually have to permanently be on treatments for the management of that condition. Now, this is, again, tricky to diagnose. So you can see the infundibulum stalk, which is basically lighting up on that particular MRI scan, where you can actually see that bright signal which is coming on that particular brain scan is coming from the pituitary stalk. And very often these are difficult sort of cases overall, which do not improve with treatments. So very often the rest of the sarcoidosis gets better, whereas people still have to have hormone replacement almost throughout their life. And then some patients completely recover, which is very good. But despite the scan becoming completely normal, people actually, other organs resolve, but people continue to have their pituitary abnormalities when we recurrently test them. Important to obviously recognize it and treat, whereas because symptoms such as fatigue, for example, within sarcoidosis might be actually coming from pituitary involvement, such as low testosterone, for example, or low growth hormone, for example. This, again, is fortunately rare. So I just showed you on that particular graph some cases of stroke from sarcoidosis. So as I said, these granulomas can become very aggressive, causing occlusion of the lumen of the blood vessels, presenting with a stroke. So that is one of our patients who present with an intracranial hemorrhage, or a bleed caused by sarcoidosis. Fortunately, very, very rare, but again, something to sort of keep in mind very often, because obviously the consequences can be quite devastating in that particular condition. There's a lot of improved brain imaging, which can help to diagnose cerebrovascular involvement, for example, particularly narrowing of blood vessels can be diagnosed with sarcoidosis, particularly with special imaging. And that's important to sort of think about. Now, among all the patients with different forms of sarcoidosis, some of the more difficult patients to start feeling the impact of the treatments we give them are people with spinal cord involvement. You do have, so that's the spinal cord involvement, which results in a very different areas can be involved. So people getting worse with time, for example, slowly progressive, for example. So these are the patients who might be diagnosed with MS, for example, over a number of years, and then respond well to sarcoidosis-related treatment, although it can take a lot of treatment. Peripheral nerve involvement, so very often the nerves outside the brain and the spinal cord and the muscles can be involved. So this can be just single nerves being involved. So people can have just dropped wrists or dropped foot, for example, or what we call mononeuritis multiplex, a number of different single nerves being involved. People presenting with a presentation very similar to Guillain-Barré syndrome, which many of you might have come across, or GBS, so that can be there, or very often neuropathy. So very often neuropathy doesn't necessarily mean your nerves are involved with sarcoidosis, but it can also be as a consequence of having sarcoid elsewhere, or what we call chronic disease-related neuropathy that can be common. And perhaps the most difficult both to diagnose and treat, so not directly related to sarcoid, Again, a lot of work currently being undertaken, but equally we understand least about is the small fiber neuropathy causing very severe symptoms and poorly responsive to any sarcoid treatment we might actually be able to give. So what I'd like to finish, I'm sorry, I'm a little bit over time. I'd like to finish is obviously by saying that neurological involvement happens in sarcoidosis in 10% of cases. So it's not as rare as we think it is. And then some people will just have neurological involvement nowhere else, which can be really difficult to diagnose and treat. Only a third achieve complete remission. So obviously, all the sarcoidosis-related treatments may not completely do the trick. It's really important, as you would hear, I'm sure, from Dr. Rice shortly, is obviously looking at treatments beyond just the standard sarcoid treatments in order to give people the relief that they require. Cranial neuropathy most common, and then obviously sarcoid develops in genetically susceptible individuals. And why I think this is really important from all perspectives of everything we've talked about, perhaps in the last half an hour or so, is understanding the pathophysiology of sarcoidosis. So why sarcoid treatments work and why they do not work very much depends on our understanding of how this actually works, and then applying those paradigms to patients without thereby causing minimum sort of drug-related damage, which very often we see, again, which I'm sure would be covered, and also developing and applying so that in the next decade or so, we see greater growth in the understanding of sarcoidosis. Thank you very much. So what we'll do now is obviously pass over to Dr. Rice for her session, and then we'll both come back on to take your questions. Thank you so much for listening. Thank you.
Hi, good morning, and thank you to everyone who has spoken already. And it is indeed a very great privilege to come and talk to you at Sarcoidosis UK this morning. My job has been made considerably easier by following on from the two excellent talks that you've already had. And I'm very grateful to Dr. Braithwaite and Dr. Arun for that. Dr. Arun has covered pathophysiology and the clinical manifestations of neurosarcoidosis. I'm going to focus on how the diagnosis is made at the moment and how we try to manage it currently. And as we go through, I'll try and highlight the challenges of the diagnosis. Some of you will have experienced, I'm sure, delays in diagnosis and found that an arduous process in terms of coming to that diagnosis, and maybe try and understand why that can be the case in some instances. We'll talk about the principles that underlie treatment and some potential future developments, as well as the current priorities that I see within that. So the diagnostic challenges associated with neurosarcoidosis occur because this is, for most clinicians, a rare condition, and it can present in any number of different ways. Clinicians mainly make a diagnosis by pattern recognition, be that listening to the histories that the patient tells us, the things that we find on examining the patient, and then combining that with our test results from investigations. And putting that all together into a diagnostic pattern is complicated when patients can present in so very many different ways and with many different organs involved. In the specific instance of neurosarcoidosis, we also have the relative difficulty of accessing tissue. So peripheral nerve biopsy and brain biopsy can, of course, be done, but these are very privileged, very precious tissues that, if you take chunks out of them, can leave neurological deficits behind. And so sometimes so therefore we really try very hard to avoid that unless it's absolutely necessary. The other problems with neurosarcoidosis are balancing those risks of investigation and treatment with the risks of leaving the condition untreated. Although some people with neurosarcoidosis are completely asymptomatic, that is usually the minority of patients. And if we don't treat it adequately, we know that we can leave very severe neurological disability. So there are both risks of over-investigation and there are risks of under-treatment. And then adding to that, again, there are risks of treatment complications. Dr. Braithwaite talked about how A pattern recognition is much easier if you have clinical experience and if you're in a clinic where you're regularly seeing patients with sarcoidosis, and I would certainly concur with that. I think in apparently isolated neurosarcoidosis, we have to have a very high index of suspicion to look elsewhere for systemic disease, as neurosarcoidosis rarely occurs in isolation. It does, but rarely. And unfortunately, in the NHS at the moment, that coordination between different specialists, often working in different units that are geographically disparate, isn't quite as coordinated as it should be. So really, this is a summary slide that describes the many different ways that neurosarcoidosis can present, both in the peripheral nervous system on the left and in the central nervous system on the right. Dr. Tarunya Arun has already covered much of this, and really this slide is us getting our excuses in early. Really, this shows all the differential, or some of the differential diagnosis that we as clinicians have to consider when we see somebody with symptoms and signs that could be associated with neurosarcoidosis. So it is a relatively complex diagnostic process that has to be gone through. However, we do have a range of diagnostic tools to try and help us navigate that process. A lot of the text on this slide is quite small. Don't worry, I'm going to talk through each of these 4 subheadings in turn. But essentially, we do have to go back to the patient and examine them as a whole. Neurologists are often not very good at that. We have to remember to examine the rest of the body as well as the nervous system, and listen to the symptoms and signs that the patients are presenting with. We can look at some bodily fluids, both in terms of blood and in terms of the cerebrospinal fluid, CSF, to try and get some diagnostic clues. Imaging is advancing all the time in terms of the diagnostic information that we can glean from this. At the moment, MRI is really the investigation that we rely on most, but advanced imaging techniques are coming through, and I'm sure will play important roles in the future. And as we've heard about on a number of different occasions today already, biopsy is the gold standard test for sarcoidosis, but has some challenges within the central nervous system in particular. So just going back and thinking about systematic evaluation of the patient, well, again, this is very basic medicine, but very important medicine, is going back and listening to the patient as they relate their symptoms and the problems that they are presenting with. There are obviously things that we can find on examination, but many of the neurological signs that we can find on examination will be found in other conditions and may not be what we call pathognomonic or particularly helpful in reaching an early diagnosis of the condition. So we have to consider other relevant investigations and liaison with other specialties. Ideally, trying to locate a place where we can biopsy to establish a tissue diagnosis of systemic sarcoidosis, and if not, do we have to think about a brain biopsy or a peripheral nerve biopsy in order to establish that? So some of the images here show a chest X-ray that has some thickening around the, I don't know if you can see my cursor, but here we call this perihilar lymphadenopathy. So these areas are much thicker than they otherwise would be on a normal chest X-ray, and can point us early in the direction of a biopsy to try and establish the diagnosis. The image at the bottom, the black and red image, is a PET scan taken from a patient with neurosarcoidosis who didn't have any chest symptoms at all, but you can see these very bright spots lighting up around the heart, almost in a little circle all around it. Those spots are actually in the lung, but again gave us a source of tissue for biopsy so that we didn't have to do that within the central nervous system. And the image, the pink image with lots of little purple dots, is an image of a typical granuloma that we've seen already a couple of times today and certainly heard quite a lot about. So looking at blood testing and cerebrospinal fluid testing, we do already have some targets that we can measure in these fluids to give us some clues as to underlying diagnosis of sarcoidosis. The one that I'm sure many of you will be familiar with is the serum ACE level. And this is often, but not inevitably, raised in systemic sarcoidosis. In neurosarcoidosis, it may be less useful, but clearly gives some pointers if you see it elevated. There are many other causes of raised ACE other than just sarcoidosis. Many of those are other granulomatous conditions, other conditions that create these inflammatory bodies or collections of immune cells that we call granulomas, but certainly sarcoidosis would be one of the most common of those. You can also, in some laboratories, and this isn't always available, measure soluble interleukin-2 receptor, which again is probably a little bit more specific for sarcoidosis, but we're still learning how to use this biomarker most appropriately. Measuring the calcium is quite important, and that's because in the granulomas, there's often an overproduction of a very particular type of vitamin D, 1,25-dihydroxy vitamin D, and there can be increased absorption of calcium in about 10% of patients. So measuring those are important, and again may give some diagnostic clues, but are otherwise important for general management in any case. And looking at the cerebrospinal fluid, we might see an increased number of white cells, the immune cells circulating around the brain and the spinal cord. Again, there are many other conditions that can do that, but it would be a little bit unusual for that to be normal in neurosarcoidosis. Some laboratories, and if certain tests are requested at the right time, can tell you as to whether there are certain subsets of those white cells, of those immune cells that are altered in terms of their ratio in neurosarcoidosis. And we in particular look for the CD4 to CD8 ratio. High protein is very often associated with neurosarcoidosis and indeed may contribute to some of that sludging up of the circulation of CSF and resultant hydrocephalus that we've already heard about this morning. And oligoclonal bands are production of immunoglobulins, or immune proteins, essentially IgG, within what we call the intrathecal space, within the space surrounding the brain and the spinal cord. And oligoclonal bands are very common in many immune-mediated neurological diseases, most particularly multiple sclerosis, but they are relatively less likely to occur in neurosarcoidosis, which can sometimes give us an additional clue. And measurement of IL-6, again, similar to the interleukin-2 receptor, isn't always available in every laboratory. Clinicians need to think about it. They need to send the test off to the relevant place. But again, we're learning how to use this in a more sophisticated way going forward. And that really highlights what we mean by looking for biomarkers. These are things that we can identify and measure that might be helpful either for diagnosis or indeed for monitoring disease activity. And this is very much an active research area going forward. Essentially, we want to make the diagnosis easier, more reliable, and less invasive from a patient point of view. In terms of imaging, we've heard quite a bit about this already, and Dr. Arun has shown us some lovely imaging of the brain, mostly with MRI scans. And indeed, we can see collections of inflammatory cells. We can see the effects of focal granulometer, be that either because of the inflammation that they cause, or indeed because of compression effects, say on the cranial nerve or another very elegant structure or part of the brain. Sometimes we see very diffuse inflammation, can often look very much like MS on standard imaging. And again, as Dr. Arun mentioned, we may see some vascular changes, perhaps less commonly. We may see some hemorrhage, which can lead to stroke, as she already discussed. And again, often because of that compression effect of granulometer, we can sometimes see disruption to the venous drainage systems of the brain and a clot there, which we call venous sinus thrombosis, very much like a DVT, which some people will have heard of in their leg, where the veins The circulation within the vein is blocked due to a clot, but when this happens from the veins draining the brain, this can have very serious consequences indeed. Unfortunately, it's a rare complication of neurosarcoidosis, but something we do need to be alert to. Hydrocephalus is this ballooning of the spaces, the fluid spaces within the brain, shown on the MRI scan labeled A. On the right-hand side of the screen, these nice kind of white fluid spaces should be nice and slit-like, but here you can see they're really quite chunky and broad. And this is because the flow of CSF, the flow of the spinal fluid, has been disrupted, either because there's a direct compression, so a direct blockage due to the inflammation within the brain, or a clogging up of its normal reabsorption system due to that high protein. And this is, again, a very serious complication of neurosarcoidosis, and often treated with a drain, as Dr. Arun mentioned. So additional things that we may see on scan include the meningeal abnormalities, again, that were very eloquently described already earlier on, most commonly leptomeningeal rather than the pachymeningitis around the outside of the brain, but both can occur. And indeed, when the meninges are affected, then it might be slightly easier to target in terms of a biopsy, because you may be able to restrict that biopsy just to the lining of the brain rather than the brain tissue itself. And that's obviously associated with a somewhat reduced risk of complications. In addition, and finally, but also quite importantly, we may see actual cranial nerves lighting up on MRI scans associated, again, with inflammatory changes. They may be thickened or they may light up with an injection of ganglion contrast. And again, all of that and the pattern in which that happens can be quite helpful diagnostically. Coming back to tissue biopsy, we've talked a lot this morning about how this is the gold standard test, about the pathological hallmark, the thing that was really characteristic about a biopsy of sarcoidosis, which is a non-caseating granuloma. And we do see these in the brain and the meninges when we're able to establish a tissue diagnosis. Clearly, when we are thinking about this, we try and avoid a brain biopsy wherever possible, but sometimes it is simply necessary because there isn't another target that we can identify despite extensive investigation. We looked at this quite a number of years ago now in our hands in Bristol, when we had to undertake a brain biopsy in patients who had neurological disease that we weren't able to otherwise establish a definitive diagnosis. Not all of these patients had neurosarcoidosis, but a significant proportion of them did. And we found that very much as you might expect, that when you have a radiological, so an imaging abnormality that you can target on biopsy, then the chance of getting diagnostic information from that was very good, and in fact it was over 70%. And if you had to do a blind biopsy, so there was no definite target that you could go for because the imaging abnormalities were in a place that were too dangerous to target neurosurgically, then your diagnostic yield was still non-zero, was 30%, but much less than for a targeted biopsy. Fortunately, in our series, there were no permanent complications of brain biopsy, and that is why we advocate it as something that can be done when you've explored other options and not found those to be helpful. But what are the things that we can try and do to improve the diagnostic process going forward? Well, we've talked about biomarkers already, and there are many different types of those, measuring the cytokines, the kind of inflammatory signals that are produced by the body in inflammation, and ever-improving imaging techniques, which are getting ever more sophisticated. I think very much that importance of pattern recognition and developing clinical expertise is incredibly important. Dr. Arun has done some excellent work bringing clinicians together to form the Rare Disease Collaborative Network, which we'll hear about later on. But this is a great platform on which to build that coordination of expertise going forward for patients with neurosarcoidosis. there is no doubt at all in my mind that increasing the multidisciplinary and speciality team working across the NHS will be really key to improving recognition of the condition and indeed coordinating clinical trials and research. From my own point of view, we've recently been awarded a pilot grant from the Foundation for Sarcoidosis Research. That's a US-based charity, and we'll be looking at cell-free DNA in the CSF. So that's essentially, you could think of it a little bit like molecular archaeology, really. It's looking back, or genetic archaeology, it's looking back breakdown products of different cell types within the CSF to try and get clues about inflammation that has happened within the brain and around the spinal cord. So that project is very much in its infancy at the moment, but we're very excited to take that forward and hopefully with SarcoidosisUK also establishing its own research grant programme. That will be something that other people can build on in addition. So coming on to treatments, well, we've heard a lot about how sarcoidosis can affect just about any organ in the body, and I'd very much agree with that. I think I would point out that some organs have a greater likelihood of causing more severe disease. That's not to underplay certain problems that people can have with other organs that aren't highlighted there. But statistically, the brain and spinal cord, the eyes and the heart are associated with the most dangerous types of sarcoidosis, at least statistically. And our treatment principles really are to try and cause remission of disease. We call that induction therapy. And then we want to try and prevent new or recurrent disease emerging, and we call that maintenance therapy. And these are really the two kind of important pillars of our treatment approaches. This is a slide that I've stolen from Dr. Arun, but I think the graphic that she presents here from the BMJ some years ago really highlights the balance and actually often tension that we feel between our treatments in sarcoidosis. So we know that some forms of sarcoidosis have a relatively low likelihood, a relatively high likelihood of remitting of their own accord and not causing any very significant tissue damage. So some people with pulmonary sarcoidosis, not all, but some will not have any treatment. They will just have their condition observed over a period of time. And the respiratory physicians know that that's something that can be done safely because there's a low risk of harm associated with that. But in neurosarcoidosis, I have to say that that's not an approach that we favour because the brain, the cranial nerves and the spinal cord, you require very little area of damage in order for that to manifest as really quite significant neurological disability. And in general, we consider, although we don't know for sure, that it has a relatively low likelihood of remission. So we are much more likely to treat early and actually aggressively in neurosarcoidosis compared to many other forms of sarcoidosis. But again, that has to be balanced with ongoing concerns around the safety of our treatments and tolerability thereof. But the agents that we have at our disposal, we've already heard from Dr. Braithwaite this morning and a little alluded to on occasion by Dr. Arun, we have this really quite standard repertoire of treatments that are available to us at the moment. And again, because of their rapid speed of action, we are often reliant on the use of corticosteroids early on. We do know that steroids have very many side effects. Again, they've been talked about already, and many of you will be very familiar with these. And we often introduce early a steroid-sparing agent so that we can try and get the dose of corticosteroid down, whilst also having that ongoing immunosuppressive effect. And many of the agents, again, you'll be familiar with and have already been alluded to this morning, such as methotrexate, azathioprine, and mycophenolate. That's not a complete list, but it's some of the most common agents that are employed. And many patients with neurosarcoidosis will respond very well to this combination of corticosteroid and steroid-sparing agent, but a proportion will not, and we have to think about escalating their treatment further in order to establish disease remission. In the past, we didn't have a very targeted therapy for this. We were generally reliant on something along the lines of cyclophosphamide, which is a chemotherapeutic agent. It's pretty hard hitting in terms of its immunosuppressive effect. It's a bit of a blunderbuss agent in terms of its spectrum of effect, but it's also quite effective. It does have a number of very significant potential side effects. It's profoundly immunosuppressive. It causes problems with fertility. It can often cause problems with kidneys if it's not handled appropriately, and in the longer term also associated with some increased risks of malignancy. More recently, we have anti-TNF agents in the case of neurosarcoidosis, and this is generally infliximab or an infliximab biosimilar. And we are now lucky to have access to that for some of our patients with neurosarcoidosis, although I have to say the criteria are, to my mind, and I think to some of the other people on the call's mind, a little bit rigid, and we're working quite hard to improve the access to that drug for patients that we think it's clinically indicated for. But as a general rule, all of these medications are immunosuppressive to some extent. There are risks of infection, there are risks of inducing malignancies, and there are also additional drug-specific side effects such as nausea, liver or kidney dysfunction, diabetes, most pertinently, of course, with corticosteroids, as we've heard about already. So the treatment can be and is often effective, but isn't to be taken lightly because of that range of side effects that can be associated with it. Calcium and vitamin D monitoring is, I think, something that's maybe not infrequently overlooked. We talked earlier that calcium can be increased in a proportion of patients with neurosarcoidosis, and that's due to the overproduction of 1,25-dihydroxyvitamin D. That is a very specific test, has to, the standard laboratory vitamin D test won't pick this up. So your clinician has to be alert to testing the right thing. But it also has to be balanced with the increased risk of osteoporosis that can be accelerated with steroids and if people have immobility due to disability. So what can we do to improve the treatment? Because although it's effective, it's certainly not straightforward, and there's a considerable burden of treatment for our patients. Well, we need to get more data. Really, that's at the heart of all of it. We need well-characterized cohorts. We need to know what happens when we treat. We need to know what happens when we don't treat. And we don't have very well coordinated and characterized data sets to help us with that. Dr. Braithwaite has talked about the importance of that and some of the things that she and her group have done to try and improve that. And the Rare Disease Collaborative Network certainly hopes to emulate some of that in addition. We also need to establish some clinical trials, because until things are properly tested, we won't really know whether they work or not. We don't have good clinical trials in neurosarcoidosis at all. Partly that's because it's a rare disease, and partly because of the relatively poor coordination of care, both within the UK and more widely. But I think there's very little excuse for that going forward, and we're working with colleagues nationally and indeed internationally to try and improve that. We should think about what are the most important clinical trials to do, and I'm sure we'll hear some more about that in talks, dedicated talks about research. But we don't know, for example, whether cyclophosphamide versus rituximab, whether one is genuinely better, in inverted commas, than the other, or if they have specific patient groups to whom they might be best suited. We also need to think about all the different novel drugs that are coming through, and also repurposing of drugs. So things that we know are effective in other conditions, might they be able to be effective in neurosarcoidosis? As Dr. Arun mentioned, the more we know about the pathology of the condition, illustrated in the graphic or the cartoon on the right, then the more options we have for targeting known drugs at those different points along the pathology cycle where we can intervene. And there are great many of those, and we have to be very careful to prioritize them most appropriately for our patients, because clearly testing all of them in parallel is something that would require a great deal of expense, a great deal of patience, and may not be the most efficient way forward. And I reiterate again the importance of biomarkers in terms of trying to predict and monitoring responses. People don't want to have to try all of these drugs in order to know which one will work best for them. It would be much better if we could predict that in advance, and if we had good ways of monitoring, perhaps with a simple blood test, how patients are responding rather than waiting for them to develop a relapse. I'll just briefly mention some additional considerations around improvement to treatment. Drugs may not be the, or at least traditional drugs, may not be the whole story. Advances in technology means that we have different ways of delivering drugs. The central nervous system has traditionally been very hard to access for normal drugs. There is the blood-brain barrier, which is designed to keep infections and other toxins out of the brain and spinal cord, but that can be unhelpful when you're trying to deliver a therapy. So nanoparticles may have some advantages in that regard. And then chimeric antigen receptor-based therapies, often known as CAR T therapies. This is a rather long-winded name for a new but very promising therapy. Essentially, if you think about how monoclonal antibodies such as infliximab have been developed, these are immune proteins that have been altered to target a very specific antigen, a very specific target on cells or tissues. And in the case of CAR T therapies, this is not a drug, but it's the patient's own cells and their own receptors on those cells that are modified to increase targeting of the antigen of choice. So this is now widely used in treatment of malignancies, including central nervous system malignancies, and increasingly being examined in immune-mediated conditions also. And in the case of neurosarcoidosis, this does have some particular promise because, again, of that access of the patient's own cells to within the central nervous system. This may be a much improved mechanism of delivery of targeting an immune modulating response. There are some other priority questions that we need to address. Can we predict who's at risk of relapse? How long do we need to leave people on these immunosuppressive drugs for? And very much as the rheumatologists have been very effective in trying to minimize the unwanted side effects of steroids in some of the vasculitides that they treat, we do need to think about that in people with neurosarcoidosis also. So overall, really, we want to develop personalized medicine to try and use all the information about the disease and about the individual patient, along with monitoring of that, to target the therapies most effectively to that individual person, rather than interventions that we know are statistically effective overall, but may not be helpful for that particular person. At the moment, we are a long way from being able to do this successfully in neurosarcoidosis, but we talked a little bit already about artificial intelligence and how that might be able to accelerate the research, accelerate interpretation of the research data that we have and to acquire it more effectively and efficiently. And I do think, again, that we're going to have to think about our current healthcare systems and how we coordinate those in order to, A, gather this data most effectively and also to implement treatments. So the current priorities, as I see them, and this is a very personalised take, I would put coordination of care and high quality research right up there at the beginning, right up there at the top. And I think the Rare Disease Collaborative Network will be a very important step in helping to do that. Dr. Arun will tell us more about it later, but it's very exciting. It's somewhat overdue, but she's done an enormous amount of excellent work in bringing that together. And the high quality research is very exciting to hear about the Sarcoidosis UK grant call, and that and others can only help but deliver the high quality research that we need. We really need to improve our mechanisms of diagnosis and monitoring to make them less onerous for patients. Biomarkers will be key to that. I think stratifying who will benefit from early aggressive treatment and who we can monitor safely would be important in avoidance of side effects and the risks of treatment. We don't really know how long we need to treat patients for. We need some data to help inform those decisions and to help predict relapse, who needs to stay on treatment, who we can safely withdraw treatment once we've got control of the condition. And drugs such as the TNF agents, anti-TNF agents, are they superior to other drugs? Then we probably think they are in terms of tolerability at least, but then there are the differences between those subclasses of drugs. We really don't know much about that at all. And there are a number of agents that are of particular promise going forward that haven't been robustly tested. Anti-IL-6 agents, tocilizumab, are just two examples that I haven't talked about in detail today, but could be picked out from the list of agents mentioned on one of the previous slides. And of course, there will be new treatments that we'll be able to use once we understand the pathophysiology of the condition more completely. So I'll just end by acknowledging some of my colleagues, particularly those in the Rare Disease Collaborative Network, Dr. Arun, Dr. Singh Curry, Dr. Fernandez, Professor Scolding, who did a lot of work on sarcoidosis in Bristol in years gone by, and Dr. Matthew Suderman, who's a researcher based here in Bristol, working with me on the cell-free DNA project. I'd like to thank the Foundation for Sarcoidosis Research for funding that, and of course, Sarcoidosis UK. Thank you.